Lovely. Thank you very much, Ms. Neri. Okay, good afternoon. I'd like to welcome members to this extraordinary virtual meeting of the Rutland Health and Wellbeing Board and to its members, to members of the public who are listening in on via Teams. We've only got one item of business on today's agenda, but there are some practical issues first. I'd like to remind attendees they need to have their cameras switched on and to please raise their hand if they wish to speak, and that for the benefit of the webcast and the recording, they need to switch on their microphone when addressing an item and switch it off when they finish speaking. I'll refer to scrutiny, the scrutiny officer from Democratic Services if I need to record a vote or for any procedural matters. Thank you. So moving along first to apologies. Jane, have we received any apologies?
Yes, Chair. Apologies have been received from Dawn Godfrey, Emma Jefferson, Faye Hirrell and Sarah Premer.
Thank you very much. Ian, your hand just went up. Was that just you were testing it, were you?
It might have been mine, Councillor Ellison. I did put my hand up because my camera hadn't switched on, but
Okay.
It's now sorted, so it's fine. Thank you.
Came through as Ian Crowe, so okay, thank you, but it's working. That's fine. Thank you very much. Item number 2, declarations of interest. Do members of the board have any interest to be declared this afternoon?
Councillor Ellison, Mike's got his hand up.
Yeah, just to jump in. Sorry, Chair, can I just check? Are we quorate as a board? Cheers.
I am told by Jane, absolutely, we're fine. Yeah, thank you. So, thank you, Mike. Any declarations of interest from anybody? No one's. Okay, that's fine. Do we have any petitions, deputations or questions, Jane?
None received, Chair.
Thank you, Jane. Questions with notice from members. Do we have any questions with notice from members, Jane?
None received, Chair.
And number 5, do we have any notice of motion from members?
None received, Chair.
Okay, so the point of this afternoon is, and the reason it's virtual, is to discuss the same-day care. So we have a presentation from Deborah Mitchell, that's what it says here, Assistant Director of Integration and Transformation from NHS Leicestershire and Rutland Integrated Care Board. So I would like to hand over to Debs and her support from Sue Venables. I'll hand over to you. Thank you very much, Debs.
Thank you, Chair. I'm going to share my screen in a moment. First of all, I just wanted to thank members for giving me the opportunity to talk through some proposals we have on same-day urgent care, and particularly it's to give advance notice and to request the support of the Health and Wellbeing Board for us going out to a public consultation exercise over this change. So I'm going to share my screen, and can somebody tell me if you can see it? I won't be able to see you when once I've shared my screen. So if you need to come in, somebody could just speak, please. Thank you.
That's lovely, Debs. Thank you.
Thank you. So as I've said, we've come to talk about the same-day urgent care presentation. We have 4 strategic programs that we have been working to across the LLR, and as part of the Health and Wellbeing Board. And apologies, I clicked my finger too quickly. And this is one of those 4. So we have our health plan, we've got the health and wellbeing plan, and we had 4 big strategic programs that we are working through. The Levelling Up programme across Melton and Rutland, improving electives and diagnostics locally, our health and care collaboration, which we've heard something about already at previous health and wellbeing boards and will continue to hear about, and same-day access. And this is about same-day access. And same-day access is in the context of all primary care access. So as I'm going through the slides, I will explain some of the different types of access and then the changes that we are proposing to make. So this first slide talks about general practice in Rutland, and as people will know, we have 4 practices: Oakham Medical Practice, Market Overton, Somerby, the Eppingham Surgery, Empingham Practice, and we have a total registered population of 42,000 residents. Some residents in Rutland register with GPs outside of LLR, and we have some patients who live outside of LLR and live outside of Rutland registered with our practices. These next points are just a useful, hopefully a reminder of what primary care and GP access is all about. A GP is the main point of contact for general health care for NHS patients. All UK residents are entitled to the services of an NHS GP. They help manage their health and prevent illness, and are trained in all aspects of general medicine. And the GP assesses, diagnoses, treats and manages illness. They carry out screening on some cancers and provide vaccinations and promote general health and well-being. And they also are the link to further onward referrals and link to hospitals. But primary care appointments and the primary care need within a local population isn't just provided by GPs, and there are other professionals that can see patients who require some intervention. So these next 2 slides, they are a bit busy, and we will make these available as part of the consultation process and to the board members following this presentation. So you'll be able to study it in a bit more detail. But Pharmacy First is one of the pathways that we encourage our population to use. And this slide just refers to all of the conditions that pharmacies can treat patients for. So ones that you don't need to go to your GP for. So the ones in green are the conditions that are suitable for referral to a pharmacist, and you can self-refer. And the ones in red show some more complex conditions relating complex symptoms related to the conditions that you'd expect to go to a GP for. I'm not going to go through the list, but it just gives you a flavour. And this next slide, there are 7 clinical conditions that pharmacists can prescribe directly medications for, and these are the 7 more specific conditions that you can go to a pharmacist and they can prescribe medicines to you. Again, there are the inclusions at the top in green and the exclusions are below. These services are for all over 1-year-olds only, and there are some specific exclusions in each one along the age group. So in terms of patients that need some intervention, there's some self-care, first of all, that we would look at people looking after themselves in their own home. There are opportunities to go to your local pharmacist for a certain number of conditions, which are what these 2 slides will link to. We've seen that you would go to your GP practice for a GP appointment, or to see another professional in that GP practice, which could be a practice nurse or one of the practice pharmacists. It could be a social prescriber, which again gives some link through about the different professionals that can provide treatment within Rutland. This Rutland same day access proposal, which is what we are looking at here, seeks to simplify and consolidate some of the existing services for on the day care and eliminate some of the confusion which exists in the service. We have a currently have a minor injuries unit and a minor illness unit within a minor injury service within Rutland. They're run from the same accommodation by the same provider, but they currently offer different types of services. The signposting is quite complex and not very clear, and the feedback that we've had from both Healthwatch and from other forms from the public are that the services are confusing and they don't know where to go for each element. So our proposal is to simplify that service and consolidate and replace the current minor injury service and urgent care service with a minor illness and minor injury combined service, which will run from upgraded accommodation within Rutland Memorial Hospital. We're proposing that the service will run for a minimum of 8 hours a day, 7 days a week. The service will be primarily appointment-based, pre-bookable, either through ringing 111 or through GP surgeries with some minimal walk-in capacity. EMAS and the Leicester, Leicestershire and Rutland clinical assessment services will also be able to access some of the capacity. The principle of having a pre-bookable appointment service allows us to get more patients seen through the day as opposed to a walk-in, and it fits with the overall Leicester, Leicestershire and Rutland urgent and emergency care strategy of talk before you walk, with the principle of making sure that patients get access to see the right professional when they need to be seen. We want to maximise the use of pharmacy first and direct booking to be explored as part of this business case. And we need to explore increasing our X-ray provision, which currently only runs at 2 days a week to 5 days a week. So we are starting conversations with University Hospital Leicester about the possibility of increasing our X-ray provision. Funding, of course, and availability of staff and demand will be key factors in us being able to do that. The provider of the service will be determined following a provider selection process. So this diagram here just shows you the different tiers and models of care, that some of which I've talked through. At the very top, you see A&E departments or emergency care departments, as you would know. Currently, the three of the main options for patients in Rutland are Leicester Royal Infirmary, ED, Peterborough and Kettering. And those are for the most complex conditions for patients that need to be seen as an emergency. The next level down are for patients who don't actually need to go to an emergency department, but need to be seen or can be seen in an urgent treatment centre. And there are 3 available with it in the broader locality. There's the city, Leicester City, UTC. There's Loughborough one and the Corby one, which is the nearest actually to Rutland residents. The Tier 2 service is the one I've just described. It's our current minor illness, our current UCC and minor injury service, which we want to convert into this joint minor illness and injury service running concurrently. Tier 1, we've got some enhanced access which services which we implemented in primary care about 18 months ago, which allowed us to open additional appointments in the evenings for GPs and during Saturday. And the Tier 0, our normal GP practice and out-of-hours service, community pharmacy service at the bottom. And the pyramid, although it's not exact in its shape and numbers, would expect gives a pictorial representation of the numbers you would expect in each area. So you'd expect the smallest number of patients needing to go to a tier 4 service, but it is dependent obviously on the condition the patient has. So some of the expected outcomes, I've covered a bit of this, but ensuring that we have 7-day local access for patients within Rutland. So we looked at a number of options. One of those options might have been not to have a local service, but because of the rurality and transport arrangements and the needs for the local service, within Rutland, we wanted to maintain a local service, but we wanted one that fitted in with the overall principles of urgent and emergency care within Leicestershire, Leicester and Rutland, but also was available and fitted in with the needs. By moving to an appointment and a joint service, it will allow us to have more appointments available. So we put some growth in place as part of the model over and above the current activity levels. We will deliver improved economies of scale, because it's quite confusing for the public, but also from the provider switching from one service to another depending on the time of day. So the minor injury service currently runs during the daytime, and then they switch over to a urgent care centre in the evening and on Saturday and Sunday. So it's confusing for the provider, but it's also confusing for the public. It also creates us the opportunity to develop modern and general practice. So it gives the ability for our GP practices to concentrate a bit more on long-term condition management for the patients, where their skills are most needed. We aim to have improved patient experience and a clearer, consistent offer, improved quality outcomes. And because we've been fortunate in being able to bid for some community infrastructure levy money, SIL money, which the council have gathered together from housing developments, we will be able to upgrade the current accommodation the services are run through, with an added benefit of providing some additional clinic rooms for open medical practice that sit alongside Rutland Memorial Hospital, and it also gives a bit of a facelift to that side of Rutland Memorial Hospital. I'm going to hand over to Stu now, who's going to talk us through the public consultation proposals, and then we'll open it up to questions from you all. Thank you.
Thanks.
So I'll manage the slides for you.
Lovely, thanks, Deb. So in terms of any proposals, any proposed improvements to health services, we strongly believe that they're better designed when the public, the people who are actually using those services, are involved in the conversations and the design. And the way that we would do this is around a public consultation. I mean, not only is this morally and ethically the right thing to do, obviously it does then support us in terms of our duty to engage, so our legal duties, but it also makes sure that we're really understanding the population and the wide socio-demographics. So it's a really important element for us to have this conversation with the public and make sure that they're involved. If we can just go to the next slide. So in terms of consultation principles and what we're doing, we need to be absolutely clear in terms of what we're consulting on, and we need to have simple information, simple, clear information. Although we do know that people receive things and want things in different ways, so we will recognise that. So for those people who want a huge amount of detail, then that would be available on our website, include all the documentation around this and how we've got to this current point. But at the other end of the scale, we recognise that sort of short, sharp, simple information on a leaflet in easy to read language is what others would want, and then we cater in the middle. We'd need our evidence to support the proposal, so a lot of the detail of the information that Deb has gone through. We've got to get the questions right. This isn't a referendum. We aren't just simply saying, do you want this, don't you want it? What we're aiming to do is really get an understanding of what matters most to people and what the impact would be on people and their families. Before we set out on this journey, we've done a quality impact assessment to understand who we believe might be negatively or positively impacted. Obviously, the consultation data gives us a huge amount of information after we've completed the consultation. So we do a second quality impact assessment, adding that data to it to give us a richer understanding. We use a range of ways to participate and provide a range of ways to feedback in all different formats, depending on who we're talking to. Proportionate timescale for people to responding. So this would be an 8-week process. And we would also enable, as part of the feedback, alternative suggestions. What haven't we thought about? What might we need to think about? And then, of course, we ensure that we put into the public domain the full report of findings, which is anonymised, so that we're protecting people. If we can just go to the next slide. So in terms of the purpose, we're giving people that voice and the opportunity to influence plans and decision making. We're informing them on how the proposals have been developed, describing and explaining the proposals and all the background, seeking their views, and as I've already said, their impact. Ensuring participation. I mean, the bottom line for this, our role is to ensure that we've utilised every available mechanism to reach out to the citizens of Rutland to make sure that they're aware of this consultation, and therefore, if they wish, to actually respond back to that. Just go to the next slide. So we'd be explaining reasons for the consultation in terms of things that I know is your bread and butter. You will know this in terms of the populations of Rutland increasing and changing. As Deb has said, access to some services can be difficult and also confusing. Buildings need to be refurbished so that they're fit for the future. And we know that there is more demand for services from GP practices, which obviously has a big impact on these proposals as well. We just go to the next slide. Obviously, the benefits, and again, I won't go over this because Deb has talked us through it, just in terms of more on-day appointments, reducing the need for people to drive outside of Rutland, because we know in terms of a rural area the complications and difficulties that causes, reducing the confusion, improving facilities, also reducing this duplication and joining up services. It's something that we constantly hear from people in terms of join your services up, talk to one another, and then obviously ultimately relieving pressure on A&E. Approaches, we will be adopting a multi-channel approach, and I'm really pleased to say that we're also, one of the things that we will be doing is something that's really worked successfully in 2 other areas that we've worked on, which is Lutterworth and Hinckley, in that we're pulling together a task and finish group. Been speaking to many people on this, and we're just about to get the invitation out to the first meeting, having got people's availability, and this will be people who are using services, voluntary and community. I'm pleased to say that Health Watch Rutland, because I know Janet's on the call, and Tracy will be contributing to that. We've had a number of conversations, those representing people with protected characteristics. We would hope that the council, we've also approached the MP's office. So that task and finish group will meet before the consultation even starts, and their main role will be to help us design the consultation. It won't be to talk around the proposals, because that is the role of the consultation itself. But we find that where we've got the power and knowledge and expertise of local people, that's where it leads to some great consultations, and that's why we're doing that. So there'll be meeting early December and early January, and there'll be lots of opportunities to discuss things in the interim. And they will help us to get that strong multi-channel approach, whether it's face-to-face work, using existing forums, using digital capabilities, using the power of those stakeholders on the ground level. That expertise with people on the ground level who know the local area is absolutely critical. And also strong internal communications. We need to bear in mind we've got a huge amount of health and care staff working in the local area. They need to know around these plans, because they're talking and working with patients and their families every day. So we will be talking to them so that they're aware. So this isn't a surprise if somebody says, oh, have you heard about this consultation and what it's about? So that is a really important element. We can just go to the next slide. As I mentioned, our role is to get out to the local population and really understand things from where they are, the way that they are living, whether whatever age they are, what gender, whether they have a disability, whatever ethnicity, whether they're rural or urban, parents, non-parents. All of these social demographics see health in totally different ways, and we need to understand it from their perspective. So we're setting out on this journey, understanding our population, and then post-consultation we will be able to assure ourselves that we've heard from all of the social demographics. Just go to the next slide. Continuous monitoring, we don't just launch this and then hope for the best. Let's hope a load of people contribute. We actually monitor and evaluate this as we're going along. We actually have a midpoint review as well, where we actually look at, are we reaching out to all our population? Have we got representative numbers from all our social demographics? Analysis is done independently to make sure that this is totally open and transparent. Regular reports, and that will be something that we would feed back to the task and finish group, and then that final independent report post consultation, which is really where the work really starts, because all of that then has to be articulated, understood, so that influences any decisions going forward. So I'll pass back to you, Deb.
Thank you. So next steps and timelines, and then we can open it up to any questions. We can commence in the governance process for the approval of this case. So we've been through some of the internal ICB governance meetings, and we've been given permission to go out to consultation from that perspective. Coming to the Health and Wellbeing Board, and we will be covering some of this in the scrutiny committee next week, is part of this wider engagement prior to the consultation. We aim to start the consultation on the 13th of January. It will be an 8-week consultation, as Sue has said. There is an associated capital business case that I mentioned earlier, and that will be submitted to Rutland County Council in February, early next year. It is currently going through, some of the proposals are currently going through Leicester Partnership Trust at the moment, their governance structure, because obviously they own Rutland Memorial Hospital. The evaluation of the consultation and impact on the service model, we hope to get to by April 2025, and service delivery to commence and capital works to complete by the 1st of April 2026. Now, we might be able to get the service delivery model in place earlier, and we will consider that. It depends on the procurement process of getting an appropriate provider to deliver that service, and how quickly we can make some of the service changes required. But we will take a judgment linked to the capital works that we'll need to go on, because obviously we will need to continue to run a service while we're doing upgrading some of those facilities within Rutland Memorial, and that's going to be a difficult piece of work to go through. So we'll need to time when the new service model links through. But by the 1st of April 2026, we hope to have our completed service, subject to the consultation and those other factors. I'm going to stop sharing there and hand back to you, Chair.
Councillor Ellison, you're on mute.
Chair. Yep.
Okay. I was just checking on my picture, it wasn't there. Okay, so thank you very much for that, Debs and Sue. Very clear. It's made me think of loads of questions, but they may well get covered. What I'll do is the process, the idea of this is so that we can actually launch the consultation at about the same time as the next Health and Wellbeing Board. So there wasn't time to do this presentation then, it would have been too close. But I still think this is a good opportunity for us to ask any questions and for Debs and Sue to think through what else might be asked of them. So can I open the floor to any questions that we might have? Put your hands up. And so I've got Mike. You're on.
Yeah, thanks. It's actually about the consultation. So, Sue, I'm trying to think how to phrase it to make it answerable, and I'm not certain I can. It's that kind of age-old conundrum, isn't it? Of it's not a referendum. We're going out to consultation. We really want to hear from you, but some people might say, "Well, yeah, but you've already decided what you're going to do." And from my point of view, is I'm listening to this thinking, well, actually, it's a really good idea. So there's a lot in there. I suppose. Is there? Where do we go? I suppose. What am I asking? What are the options? What is kind of negotiable and what isn't? And I'm almost trying to predict where some of the consultation responses could come from, where we could get ahead of the curve and think about how we'd respond to them. So I'm kind of asking you to think about what will come out of the consultation before we've started. But the score. Want it to be meaningful, and there is resistance from people who think it's a done deal. It's a lot easier to ask that question when you're doing a much more negative consultation, because people go, well, you're shutting the service, you've already decided, but what is there any thinking at this stage, I suppose, in terms of where the likely sticking points are going to come from, what might be up for discussion?
So Debs has just put her hand up. Do you want to come in first, Debs, or should we let Sue have this one?
Yeah, I'll take the first bit and then Sue can come in. So one of the things I probably didn't go through, I seem to have managed to put my hand up twice. I don't know how I did that. I didn't cover how we got to the position that we're in, and I think this might give you a bit of an indication, Mike. So we had. When we introduced enhanced access service, what we should have done is close down the urgent care centres, because the money to fund enhanced access, which was part of a national initiative, was currently being spent on urgent care centres across LLR. We didn't want to do that for a number of reasons. We needed time to actually assess what we needed locally. We needed to look at how enhanced access was being implemented. So we extended the contract for the UCC, and it gave us the opportunity to also look at the minor injuries unit at the same time. So we had two workshops that we ran last year, 6 months apart, with clinical representatives from Health Watch, all of the GP practices, from the current provider. And we talked through some of the feedback that we already have received about the services. And also we were fortunate that Health Watch had done a recent visit to the UCC minor injuries service as part of their general work. So we knew some of the issues that were already coming out, and talked about what our options might be. So one of the options would be to close down that service in line with what the funding arrangements. And we quickly decided that wouldn't be a right option to go with for the public, because of the need for local services and transport arrangements, the makeup of the population in Rutland, etc. We could have left the services as is, but we knew that wouldn't address lots of the current things that the public were telling us about those services. So we discarded the leave as is. We discarded closing down the UCC because we would lose local access to appointments. So we explored combining the two services together, which would hopefully give a clearer pathway for patients to know when they've got an urgent care need that doesn't need an urgent treatment centre or an emergency department. They go to one place at one time, and that's where we came up with this model. Now, some of the things that we think the public will come back to us about: opening times. So we've said that the service will be open 7 days a week. We are proposing that those opening times would be 1 o'clock until 1 p.m. until 9 p.m. They don't have to be those hours. We're suggesting those hours because it gives them evening coverage across Rutland 7 days a week, and it sort of supports the use of primary care at the beginning of the day. But the public might want to service, for example, 10 till 6 or 9 till 5. So opening times is one of the things that we want to hear about and can be influenced. I think one of the other elements that we expect to come up is X-ray availability. We've not been able to solve this prior to going out to consultation. So currently, X-ray provision is on 2 days per week for the minor injuries service. We would like it to be open 7 days a week, but we don't have the funding, the staff, or in fact the overall demand to keep that service open across 7 days a week for the full hours. We want to explore opening X-ray for longer hours, and that's something that we're working to. So we know that we haven't solved all of the local problems, and I'm expecting that to come up as part of the consultation, but we're being open, honest and upfront about where we've got to and what our ambitions are the future. Now, patients in Rutland do go outside of Rutland for their care. There's a natural flow, for example, to Corby and Stamford. And of course, that means part of the NHS pound for Rutland is being spent outside of our area. If all patients came into Rutland only for their services, then we would have more resource available to be able to deal with that X-ray position more easily. But of course, then that goes against patients' choice. So we're interested in what the public want to say have to say around those things. I think Deb, they're the main things.
I think, Deb, the only thing I would add to that as well, Mike, because you're quite right to answer this question. The public also don't see the health service in the neat little boxes that we're trying to do a consultation on. And that's quite right. You know, going to a facility, they will link it with other things. Where am I going to get my prescription from? Will my records be updated? So if I go to my GP, will he know what care I've received? So these are all the thought processes that we've already talked to a number of patients about. So those are the other things that we want to know, because this isn't a neat little box for the public as much as the NHS would like it to be. We've got to understand the full journey, right from when somebody becomes ill through to hopefully where they're recovering or being referred into other services. So it will be a broad brush approach.
Back to you, Mike. Thank you.
Yeah, just to say thanks both. I think that's really useful and really interesting. And I know I'm getting ahead of the curve a bit, and it's for the consultation to tease that out. But I think you're right. I suppose it's that kind of reassurance that when we go out to consultation, if we can take people through the kind of the case for change and how we got here. So it's almost like this is a response to what you have said to us and what we know about, and then please consult on the detail around it. You know, if that puts in the context of whole patient care and changes, you know, nationally in terms of service provision that we've had to respond to, just gives all that kind of backstory, which I think will reassure me and hopefully reassure the public about where it's come from, why we're doing it, and then what is within our kind of gift to change as part of the consultation, which you know, hopefully it's that helps to get a decent response, and it's all well and good, but it's a really good story to tell there, I think.
Thank you. Right, before I jump in with my questions, anybody else got any questions they'd like to? Janet, I knew you'd do that because you've been very quiet, Janet, and I've been like, Janet will come along any minute now. It's yours. No, don't say sorry.
Sorry. Yeah, I mean, one of the very first conversations I had with Deb when she started in her current role was about urgent care and that we must keep it here in Rutland. So, you know, the developments are really, really welcome. So thank you, Deb, for the amount of hard work you've put into this. I've just got a couple of questions, really. One, is there going to always be somebody on duty who can prescribe? You know, so if a mum and a poorly child goes and they need some, I don't know, some medication, will they be able to get a prescription? Is my first question. My second question is more about patient flows. If a patient either can't get an appointment with our urgent care centre, I think they're automatically signposted to say Corby. If they go to Corby and require secondary care, does that mean that they then have to go to Kettering, or can they default back to Leicester or Peterborough according to their choice? Thank you. Thanks, Janet. I'll answer both of those as best I can. The answer to the first question is something that we will aim to confirm with the provider. So we've got a clinical model which talks about the types of services that patients need to go there for, of which having a prescription is obviously one of the outcomes. We need to sit down with the provider to ensure that the proposal that they come back with allows us to do that. But we're a bit chicken and egg with this. It's almost, we have to go through the process and through that procurement process. But we will aim to stop patients having to go from one place to another.
Yeah.
We're not going to be able to do that completely because of the X-ray element until we get to a position if and when we can sort that out. But we will I will certainly and we had already made note of the prescription element first. With regards to patient flows, patients should have a choice about where they go. So any provider that they go to, whether it's, even if you go to your GP, you should have a choice about which secondary care provider you are referred to. So I think that if I don't know if that question has come from suggestion that choice is not currently there, and if it isn't, that we can pick that up with some of those providers.
No, it's not. It was as you were talking and saying that, well, it has to a degree. I was talking to an aged gentleman from Uppingham, and at one particular point in his time, he was visiting 3 different hospitals, Kettering, Peterborough and Leicester, because of circumstances and where he'd been initially directed to by, sort of services. And he was saying, I'm just running around the county all the while. That was not just for himself, but for him and his obviously elderly wife. So it seems to me that there's a risk that if people are directed by NHS 111 to one or another hospital, could that same situation be repeated time and time again? And you've got older people chasing around from one county to another county to another county.
Yeah, it is a good point, Janet,
Yeah.
and I think we can pick that up with some of the discussions and conversations with our providers. Obviously, for a same day appointment, whether that's going to an urgent care centre or a treatment centre, then that could be anywhere, and patients will go where there is the available capacity. But for ongoing care and outpatient referral or inpatient, there should certainly be that choice. And I know, for example, EMAS do check with patients on the border where they've previously been an inpatient, so the records are, they know that there's some history there. So that is a normal principle that's picked up, but we will pick that up as part of our conversations with other providers.
I think it should be made clear to patients that they do have a choice in where they go onwards from that. I don't think everybody actually knows they have a choice. I don't think everybody at the point of crisis have got the wherewithal to make that decision about where they go. So I think the discussion, I don't know, I'm not telling you how to do your job, just can you bear it in mind?
Yes, of course, and you pick up an important point, Janet, actually, because and Sue touched on it. We need to help patients get to the right place, which is a bit about the talk before you walk. If patients who can be seen by a pharmacist go to a pharmacist, that frees up appointment and space for the patients who need to be seen by a GP, or for patients who need to be seen in our minor injuries, minor illness service, or an urgent treatment centre or A&E. So that those services are staffed and constructed based upon patient need, but we need to help the public know where to go and to get the best outcomes for themselves, but also the other people accessing services.
Thank you.
Thank you, Janet. I've got 3 questions before I start. Anybody else want to jump in with a question? Tim, did you want to ask about your children? Is there any issue of exclusion of under certain age groups, do you think? Or will that depend on the provider? Debs. Sorry, that was me stealing Tim's question to give to Deb.
Yeah, well, no, Diane, I think that's a good point. And actually, obviously, children form an important part of those who come to seek medical help.
Absolutely.
So, yeah, that needs to be probably in the questionnaire, in the consultation. Make sure that it does include children as well.
Yeah, sorry, that was just.
So yes, very good question. It's an all age service, but as I touched on, and when I was talking about the pharmacy and the different levels, there are some conditions for babies, for example. Pharmacy is not suitable, and one of the things that we want to be able to pick up as part of this consultation and change is some post implementation or pre-implementation, post service model confirmation, pre-implementation, some engagement with the public about how you navigate your way around
that was
primary
me giving
care.
you that one. That was my in for you then, Debs, because that was my next questions. This depends on really good communication. If let's assume it is accepted, and it's the communication to the public of signposting of where to go and who can and who shouldn't go there. And I think it's key. So you've answered one of my questions, but my two questions now are ownership. So quality, I love quality. You know, I'm like with me and my quality. If it's going to be run and owned in inverted commas by another private sector, really, isn't it? Would you call it a private sector, or is it a subsector of the NHS?
Yeah. So we don't know who the provider will be yet, and that will be a part of the process that we need to go with. But there is a governance process associated with any provider of NHS services for which we commission. So the ICB commissions that they have to pass quality standards, performance standards, and we monitor the performance of that contract as it goes forward. So whether that's an independent provider for elective services, for example, that some patients would choose, or whether it's one of the big NHS providers.
It was just so that when there's complaints happening, they know where it comes from. Mike, back to you again.
And I guess in terms of a group or a panel that might score those bids as part of the commissioning and procurement process, would that be a kind of, I mean, it'd be ICB professionals? I suppose the question is the level of Rutland specific knowledge that would be in there. I'd expect you to be in there, Deb, but is there a chance for, lived experience, Health Watch, the patient participation to be part of that scoring routine as well?
I'd need to come back on that, Mike, because it all depends on what process we end up going through, and that is subject to the model that we finally agree. So that's that. But I will make a note of that, and we can come back to that when we get to that stage of the process. But we can't answer it now.
Right, back to Janet and then Sue.
I don't know if Sue was coming into.
Sue, are you adding on to Deb's?
Yeah, I am. I mean, obviously, as well, we would ensure that all the data that is coming from the consultation, that always, if we're commissioning services, then goes into the available markets information for that provider, because they would need to know what the what patients have said, what's important to them, and impact. So that's part of the reason as well, and utilization of the consultation data and that business intelligence that it provides to inform that.
Lovely, thank you, Sue. And back to you, Janet.
Yeah, thank you. It's just talking about contracts, etc. It's my understanding that the current providers, DHU, their contract runs out in 31st of March 2025. So what's going to happen between 2025 and 2026 when you're hoping to go live?
So we're in current, sorry, Chair, I've popped right in without being asked. We're in current discussions with the provider, and our intention is to offer an extension of the contract while we move through this process.
Thank you.
Thank you very much. And then my last one is reverse referrals. Presumably, if we are referring to Corby at the moment for many of our urgent care, they are full capacity, they'd be sending them to us, wouldn't they? Is that being predicted?
So yeah, so we have, as part of working out the sizing of the model, the appointment times, etc., we have information on cross-boundary flows. Yes. So we have patients who come into the current Rutland services from outside of Rutland, both from places like Melton, Market Harborough, but also from outside of Leicestershire and Rutland. And we have patients that go the other way. We have built growth into the service model, so we will be aiming as part of discussions with the provider to offer more appointments available than currently are undertaken. And we will need to monitor that, and we'll need to monitor how the use of the service. I mean, in an ideal world, if we get the service right, and we can increase the X-ray provision at some point from discussions with our provider, that actually more patients would choose to come in to Rutland, and that obviously will allow us to continually develop the services as they go forward.
Fine, thank you very much. And one last question. I'm guessing this one, and it's probably not a difficult one. There is support for this from the existing GP practices within Rutland. Do we know of that, Debs?
So yeah, all of the GP practices were involved in the 2 workshops where we talked through the model. It is a possibility, for example, for GP practices to be a provider of these services, and that's some of the model that is discussed is being considered in other places. So yes, they are supportive of what we are trying to do. I think they would like an all singing, all dancing urgent treatment centre like most people, but we don't have the numbers of patients that require that service
at the moment.
At the moment in our area. And to be honest, I don't think we ever would unless we had more patients coming outside of Rutland into Rutland to use the service.
Right, I think we've all had the opportunity to ask any questions. Does anybody else want to ask anything or clear anything up? That's been really interesting, very useful. Thank you, Debs and Sue. So as I said, we need to have discussed this as a board. So we've noted the contents of the presentation, and I'd like to seek approval for it to go up to consultation. So anybody, oops, Debs has got her hand up again.
So I just need to ask Jay for a point of clarity. Obviously, I'm a member of the Health and Wellbeing Board. Should I be declaring a conflict of interest and staying out of any vote? Jane?
What do you think, Jane? Oh, yes, I like that face. That face was a wonderful. Ooh.
Well,
let's go back to Mike's question. If without Debs, are we quorate?
No.
David's nodding at me. David's, are you
Well,
nodding?
so I was nodding because who's going to, let's go through a vote and say who's going to abstain or disagree, because kind of it'll get, I think it'll get carried without Deborah's point. So therefore we could vote on it. It would be solved if Deborah.
And what is quorum, Jane? How many do I need?
4.
Oh, David,
including a member of the ICB and Councillor Smith.
Hang on, 4 including. Why have we got to have Councillor Smith? What's so special about Councillor Smith?
I'm very important, that's why.
Oh, I know you're important. Sorry, Councillor Smith. Why him?
Because he's a councillor.
Oh, okay. So Councillor Smith and me, we have to vote, or do I not count?
You don't count at this stage.
Oh, thank you. So all I could do is I could cheat and say, Janet, what do you think? David, what do you think? Mike, what do you think? Adrian, what do you think? 1, 2, 3, 4.
Sorry, can I just clarify at this point, all you're asking is for the board to approve that it goes out for consultation?
Yes, that's all I'm asking for.
Yeah. So, Mike, what do you think?
So, back to the choracy bit though, Jane. Does that mean that we're not quorate because Deborah's out from the start, or are we still quorate for the purposes of the board, but it doesn't actually matter in terms of choracy of the vote?
Well, board was 4. Quorate was 4 for the board.
But needed
so
an ICB member.
Deb, even without, does it have to have an ICB? Sorry. Yeah, you're right.
Yes.
She's back in then.
So, yes, Deborah, because there's no financial gain for Deborah or the ICB, we're only asking for approval for this matter to go out for consultation. So yes, you can vote on it.
Oh, maybe you've got more input. You're more input than I am now. So, okay. So all of those in favour, please raise your hands or press the button. Okay, 1, 2, 3, 4, 5. Adrian, are you not counting?
No, because I'm not a voting member.
Are you not?
No.
Oh,
I'm an officer.
So you and me don't count. Okay.
No.
And Sue, we know is a visitor, so that's fine. Debs, Jane, are you happy? You got enough there?
David, are you voting yes or
he
no?
voted.
Yes.
He waved at me.
That's
So
okay. I need to just double check. That's okay.
1, 2,
Simon.
3, 4, 5.
Yes, thank you. Yeah, that's unanimous, Chair.
Lovely, thank you so much. That's perfect. So nobody against, no abstention. So we've resolved that. Mrs. Sorsky's back. She's popped back in. So all those in favour of we've all agreed, and so we resolved that we've noted the content of the presentation. We've approved it. So this will now go to our next meeting in January the 13th. No, when's the next meeting? 14th of January. And we're going out to consultation on the 13th, so the day before. So we will wait that point, and there'll be a plan to communicate it across all of Rutland, won't there, Debs? That could be part of your consultation process.
It will, and actually we are very fortunate in Rutland because we have a very engaged public, and as we've seen with previous for the surveys or requests and responses, we do have a good response rate in Rutland.
But if we can encourage as many people as possible to. Jane, do you want to say something now?
Yes, Chair. It's just to let everybody know that under current legislation, decisions can only be made formally in meetings held face to face. So decisions in principle can be taken during virtual meetings, but they must be carried forward to the next in-person Health and Wellbeing Board meeting for ratification. So just to confirm that this decision of approval will therefore be ratified at the next meeting, which will be on the 14th of January.
Do we then have to actually delay it by a day? Is there a legal? We can go on the 13th.
Yeah.
Lovely. Sorry, Mike.
But provided, and here's a plea, please don't change your mind on your decision today between now and the 14th of January.
Yes, because that would cause problems, wouldn't it? Because we won't have ratified it. Lovely. I think as long as I think everyone seems very happy, Mike. I don't think we have any problems here, and it's going to scrutiny as well. They need to agree it. So the agreements will be in place. It will go out on the 13th of January. So please, as I said, please encourage anyone you know to put their views forward and make sure we get a good spread of responses, particularly from the hard to reach areas. They're the ones we're after in particular, so we can get people's views. And then when it happens, we will have a communication process for this implementation. But we've got a while before we start on that one. So thank you very much. Is there any other urgent business that anyone would like to bring up? Jane, have you had any requests for urgent business?
None received, Chair.
Thank you. And the date of the next meeting, as we've heard, is Tuesday. We're back to our proper Tuesdays, the 14th of January at 2 p.m. Face to face. So thank you very much indeed for all making time to come and see us, and we'll see you in January. So thank you and goodbye.
Meeting closed.
Oh, meeting closed. Thank you.
At 4:05 p.m.
4:04. Thank you so much.
Thanks, Chair. Thanks, Jane.
Thank you. Thank you, everybody. Thank you very much, Jane.